Good day, everyone. I'm Dr. Ronnie E. Baticulon, Associate Professor and Pediatric Neurosurgeon at the University of the Philippines, Philippine General Hospital, and today I will discuss the endoscopic treatment of hydrocephalus in infants, with focus on endoscopic third ventriculostomy and choroid plexus coagulation, or ETV+CPC. These are the objectives of the lecture. I would like to acknowledge that I have received support from Pure Neuro, who sponsored my training for 6 weeks in Pure Children's Hospital in Mbala, Uganda in 2016. Pure subsequently and generously provided the surgical equipment that I needed to be able to serve our patients with hydrocephalus here in the Philippines. In 2017, we estimated that approximately 383,000 cases of infant hydrocephalus are diagnosed every year around the world. Combining congenital and post-infectious etiologies, the incidence ranges from 128 per 100,000 births in North America to as high as 497 per 100,000 births in Africa. When we surveyed general and pediatric neurosurgeons in Asia and Australasia, we showed that almost all respondents treated hydrocephalus in their clinical practice. This was true regardless of level of training, country income level, or geographic region. As such, it can be said that the treatment of hydrocephalus should be part of any neurosurgeon's skill set. The most common surgical intervention for pediatric hydrocephalus remains to be the insertion of a ventriculoperitoneal shunt. Here we have the low-cost Chabra shunt alongside a more expensive shunt with a fixed pressure valve. We do know from the shunt design trial and subsequent studies that shunt performance remained the same regardless of shunt type. What does that mean? Between 20 to 40% of shunts can malfunction within the first year of surgery. With the implementation of shunt protocols and standard use of antibiotic-impregnated shunts, shunt infection rates have been reduced to 2 to 6% in many centers. However, in the absence of these, infection rates as high as 20 to 30% are still observed at present. In this regard, no doubt, endoscopic third ventriculostomy is an attractive alternative to VP shunting for the treatment of pediatric hydrocephalus, especially in rural areas and low-resource settings where lifelong monitoring and follow-up of shunted patients may be difficult or hindered by distance to a hospital where neurosurgical care is available. In this 2019 meta-analysis of 14 studies with over 8,000 patients, ETV had a lower risk of post-operative infection compared to VP shunting. There was no difference, however, in the rates of mortality, CSF leak, and reoperation between the two groups. Interestingly, patients who underwent ETV in Europe and Africa had lower odds of reoperation. In 2005, working at Pure Children's Hospital in Uganda, Dr. Benjamin Wharf published his analysis of 550 children who underwent either ETV alone or ETV with choroid plexus coagulation. These were mostly infants younger than 1 year old, with 58% of patients having post-infectious hydrocephalus. What did his study show? CPC did not seem to offer an advantage over ETV alone in children aged 1 or older. However, among infants less than 12 months, the success rate of the procedure increased from 47% to 66% when you added choroid plexus coagulation to ETV. Aside from patient age, the etiology of the hydrocephalus also mattered. The intervention was more likely to succeed in infants with non-post-infectious hydrocephalus, such as aqueductal stenosis, and those with myelomeningocele. In contrast, the difference in outcomes was not significant among those with post-infectious hydrocephalus. What could be the explanation for these observations? In obstructive hydrocephalus, such as aqueductal stenosis or tetrachgliomas, the straightforward reason is that ETV provides an alternate pathway for CSF flow. Ablation of the choroid plexus also reduces CSF volume, which is primarily produced by your choroid plexus. However, These would not fully explain how ETV+CPC seems to arrest hydrocephalus as well, even in patients with idiopathic or communicating hydrocephalus. Residual choroid plexus is also present in the third and fourth ventricles. Dr. Warf proposes that ventricular enlargement is driven by pulsation forces in the brain, and this is especially important in younger infants, whose brain tends to be more compliant. In this regard, CPC reduces the pulsations from the choroid plexus, while the ETV serves as a pulsation absorber, dissipating the forces that drive ventriculomegaly. Moreover, reducing these pulsatile forces also decreases venous pressure and generally improves capillary absorption of CSF, which is an important pathway in infants whose arachnoid granulations have not yet matured. Driven by these encouraging numbers from Uganda, neurosurgeons from around the world have since published their own experience with ETV, with or without CPC. From the Hydrocephalus Clinical Research Network in North America, their largest study to date documented a success rate of around 45 to 48%. Infants less than 1 month of age and those with hydrocephalus from intraventricular hemorrhage were more likely to have ETV failure. In Japan, this small long-term study showed that 50% of children were shunt-free at age 5, with no difference in the developmental outcomes among shunt-dependent and shunt-free children. Finally, this retrospective review of 82 children who underwent ETV+CPC in Haiti reported a similar success rate, 52.2% being shunt-free after 6 months. They had, however, two deaths from post-operative seizures. So how does one integrate ETV and CPC in their clinical practice? Patient selection is key. Most pediatric neurosurgeons are familiar with Kulkarni and colleagues' ETV success score, shown here, which predicts the chance of having a successful ETV at 6 months post-op. It considers patient's age, etiology of the hydrocephalus, and prior shunting. Between these two patients, it is more reasonable to offer ETV as primary treatment for hydrocephalus in the first child. 2 years later, Kulkarni and colleagues published their validation study, in which they showed that the ETV success score, when used in different centers worldwide, was a good predictor of outcome. In my practice, I generally offer ETV with or without CPC when the ETV success score is 40 or higher. The threshold varies among pediatric neurosurgeons and the centers where they practice, but the important thing is to discuss with the parents so they know what outcome to expect, and they can decide whether or not to accept the risk of getting a second operation following ETV failure. Once a decision to perform ETV+CPC is made, preoperative workup includes cranial imaging. In low and middle income countries and rural areas, where an MRI is generally more expensive and less accessible, CT scan is usually sufficient to evaluate ventricular anatomy, adequacy of prepontine space, disposition of the basilar artery. You must plot your trajectory to identify an ideal entry point. Inspect the width and the foramen of Monro, thickness of the third ventricular floor, as well as that of the massa intermedia, which may block your way when doing your ETV. If you're able to get an MRI, make sure to request for CIS or CISS or Fiesta sequences to identify septations and any scarring of the prepontine cistern. Patients with extensive scarring of the prepontine space based on preoperative imaging should likely just undergo outright VP shunting. A percutaneous transfontanal ventricular tap may be necessary, particularly when CNS infection is suspected. This will also help you evaluate whether the CSF is clear enough for neuroendoscopy. For equipment, I use a flexible endoscope for my ETV+CPC cases. With this, I am able to navigate all the way to the temporal horns of the lateral ventricles using just one entry point. You may also be able to do this with a rigid endoscope, but only in those with just severely thinned out cortical mantles. I use a bugby wire and monopolar electrode to ablate the choroid plexus. The camera head, light source, cable, and monitor are standard equipment for neuroendoscopy, similar to those used in other surgical specialties. The patient is positioned supine with the head turned to the contralateral side. A semilunar incision is made over the anterior fontanelle. I make a linear incision in the dura, followed by coagulation of the pia. I make the incision just large enough to accommodate the endoscope. I cannulate the lateral ventricle using either a blunt trocar or a French 5 or 8 feeding tube, and then obtain CSF for analysis. After withdrawing the trocar, I then insert my endoscope. I perform the ETV first. The stoma can be enlarged using a Fogarty balloon, or with experience, using gentle manual traction. The naked basilar artery must be visualized to ensure adequacy of the ETV and to ensure that you are not anterior to Lilliquist's membrane. The prepontine space is inspected for any membranes, and if possible, these are cleared. Choroid plexus is coagulated on the ipsilateral side. You must just brush over the choroid plexus, avoiding the ependyma. Make sure not to bury the electrode into the choroid plexus to avoid bleeding. You must follow a sequential pattern from the foramen of Monroe, going to the atrium, and then eventually navigating to the temporal horn. This, I think, is the most difficult part. I do septostomy if needed, and then perform choroid plexus coagulation on the other side, performing the same steps. After performing the CPC, I inspect the ETV stoma for any debris, making sure it's still patent. I slowly withdraw the endoscope and inspect the tract for any bleeding. Bleeding is usually controlled with irrigation or gentle pressure. Watertight dura closure is a must, so I try not to burn the dura during opening so that I can close it nicely, and then skin closure and wound dressing as usual. Here I'm going to show you a standard ETV plus CPC. Take note that the head of the patient is positioned supine and turned to the left. Hence, anterior is on the left side of the screen, posterior is on the right side. The patient's right side is at 12 o'clock, and the patient's left side is at 6 o'clock. Here you can see me inspecting the anatomy, looking at the right and then the left choroid plexus. At this point, I'm getting ready to perform the ETV. Here's the thinned out floor of the third ventricle. I take a moment to look back into the aqueduct, and that's the massa intermedia at the center. Here I create the stoma using the bugby wire. I usually press onto the clivus. This is especially helpful when the floor is thick. In this patient, I widen the initial opening using a Fogarty balloon, inflating and deflating as necessary. And then I usually insert the endoscope into the stoma. The endoscope diameter is thin, it's just around 4 millimeters. And here you can see the naked basilar artery on the right, and I'm satisfied that there are not many membranes. Then I proceed to choroid plexus coagulation. You can see I start with the choroid plexus on the right side, beginning at the foramen of Monroe. I make sure that I don't coagulate the ependyma and the surrounding veins within the ventricles. I follow a logical order from the foramen, going to the atrium, and then, as I've said, navigating to the temporal horn. You can see that the choroid plexus changes in color from red-orange to pale yellow after it's been successfully coagulated. Here, this is choroid plexus coagulation on the atrium. You just let the choroid plexus bounce off your color electrode. If there's bleeding in the choroid plexus, what you actually need to do is to coagulate just next to the point of bleeding. You must resist the urge to pull out the endoscope because you will lose visualization. This is choroid plexus coagulation on the other side. In this patient, there was no septum to perforate anymore. And finally, this is just to show you how we navigate into the temporal horn. You can either go to the temporal horn from above or below. In this patient, this is going to the temporal horn from below. And see how you could chase the choroid plexus all the way. After the CPC, make sure to inspect the stomach and that your ETV remains patent. Prophylactic antibiotics are given at induction at least 30 minutes prior to skin incision. One more dose is recommended post-op. Some neurosurgeons have advocated for prophylactic anti-seizure medications as well, considering that ETV requires entry through cortical tissue. It may also lead to subdural fluid accumulation and pneumocephalus, both of which may induce seizures. Vomiting and fever are in the immediate post-operative period are not unusual and should be addressed prior to sending the patient home, which is usually in 2 to 3 days, sometimes a bit longer, especially if the patients live far away. Routine wound care is advised. I generally advise my patients to follow up at 2 weeks. The reported morbidity and mortality rates from ETV+CPC are low. In a 2016 systematic review, adverse events and mortality risk were 3.7% and 0.4% respectively. Perhaps the most dreaded complication among these is hemorrhage. Most bleeding can be controlled with irrigation and gentle tamponade. In the event of massive IVH, the procedure should be aborted and an EVD left in place. The risk of CSF leak and subsequent infection is generally mitigated by ensuring that the dura is closed in a watertight fashion at the end. As briefly mentioned earlier, here are the most important predictors of success. ETV+CPC is more likely to fail in very young infants and those with post-hemorrhagic and communicating hydrocephalus. After performing an ETV, if the prepontine cistern is noted to be heavily scarred, I would recommend just leaving in a shunt in the same sitting. Kulkarni and colleagues have also shown that greater extent of CPC was associated with higher success rate, highlighting the need to complete CPC on both lateral ventricles whenever possible. So how do you monitor patients for ETV failure? This is an important graph that shows when an ETV is most likely to fail compared to when shunts do. ETV failure is most likely to occur within the first 3 months, but around 6 months, the relative risk becomes progressively lower compared with shunting. Meanwhile, the risk for shunt failure continues and is lifelong, such that between age 2 and 3, the two curves here have now crossed and reversed. In other words, if an ETV has remained successful at around 6 months post-op, you may be able to expect that it will remain patent afterward. When do you suspect ETV failure? Dewan and colleagues proposed looking at 3 things: a bulging fontanelle, progressive macrocephaly as plotted on head circumference charts, and enlarging ventricles based on frontal-occipital horn ratio, or if you prefer, Evans ratio. Note that the presence of one clinical finding does not automatically mean ETV failure. However, patients who had all 3 required subsequent reoperations. An evolving paradigm in the treatment of pediatric hydrocephalus is that large ventricles do not always mean that your treatment, whether ETV or shunting, has failed. In this randomized trial of infants with post-infectious hydrocephalus in Uganda, patients who underwent ETV+CPC had a generally higher CSF volume compared with VPS group post-treatment, meaning to say they had larger ventricles on post-op imaging. However, there was no significant difference in brain volume and cognitive outcomes at 12 months after surgery. This just drives the point. Don't treat the scan. Evaluate the patient clinically. Look for signs of raised ICP such as sunset eyes, dilated scalp veins, LR palsy, and most important, assess the patient's developmental milestones. Redo endoscopy may be offered at the time of ETV failure. If during re-op the stoma is patent, then a VP shunt is inserted. However, if the stoma is found to be obstructed, you may actually offer to redo the ETV. In the Ugandan experience, ETVs that fail early or within the first 3 months are more likely to require shunting. Finally, here are illustrative cases we've seen at the Philippine General Hospital. First patient is an 11-month-old infant with macrocephaly and a bulging anterior fontanelle. The patient was seen by a pediatrician and started on acetazolamide. Imaging showed a posterior fossa cyst, which you think is a big pouch cyst, associated with supratentorial hydrocephalus. You can see the nice trajectory here, and I computed the ETV success score to be 70%. So I performed ETV+CPC on this patient. Post-op, you can see that even though the patient's head circumference remained above average, it was now starting to follow the curve of the trajectory of the normal curves. True enough, when we repeated imaging 6 months later, you could see that even though the ventricles remain large, the brain volume has increased. The patient was weaned off acetazolamide, the anterior fontanelle closed, and he remained developmentally at par for age. So you could consider this as success in ETV+CPC. The second patient is a 6-month-old with macrocephaly and sunset eyes. There was no known history of perinatal infection, but CT showed communicating hydrocephalus. In this patient, the computed ETV success score is just 40%, but the parents were amenable to doing ETV+CPC first in the hopes of making their child shunt-free. I performed ETV+CPC, and initially there was a decrease in the head circumference. However, on monitoring, you could see that the patient's head circumference again began to accelerate. And so we repeated the imaging, and you could see how the ventriculomegaly is actually increased with thinning of the cortical mantle. At this point, we just decided to put in a shunt. So this was a treatment failure. After the shunting procedure, the patient's head circumference has stabilized, the brain volume has increased, the ventricles have decreased, and the patient remained at par for age. It is important to highlight that even though your ETVs can fail, the outcome can actually still be good as long as you monitor them properly. In conclusion, ETV+CPC is a safe and effective alternative to VP shunt insertion for the treatment of hydrocephalus in infants. Investment in equipment and their maintenance is necessary, but sustaining a neuroendoscopy center is possible, even in low-resource settings. Just like shunts, ETVs can fail. That's why monitoring is critical, especially in the first 3 to 6 months. A learning curve exists with a flexible endoscope, but it's less steep with prior experience in rigid endoscopy. This is me learning how to use the flexible endoscope on a 3D printed skull in Uganda, so practice is important. And here's me doing the procedure in an actual patient. At this point, I would like to acknowledge my mentors, Dr. Peter Sianyonga and Dr. Justin Onen, who patiently trained me when I was with them for 6 weeks in Mbale. So back home, this is me paying it forward and serving our Filipino children. That's me with our residents at the Philippine General Hospital. If you have questions, you may reach me on Twitter at Ronnie Bats or request for my email to the course organizers. Thank you for listening to this lecture. Keep safe, or as we say in the Philippines,